Hi, my name's Jesse. I'm a PhD student at the University of Edinburgh, and I'm going to talk to you about our paper, Confounder where image synthesis for pathology segmentation in new magnetic resonance imaging sequences. When new MRI sequences are first developed, we don't have access to any data to train segmentation models. Two sort of commonly studied settings in which we lack data are the unsupervised domain adaptation setting. And here we have labeled data from a source domain and then unlabeled data from a target domain. And then there's the, in this case, single source domain generalization setting, but we only have data from one source domain. For the case of newly developed MRI sequences, we have an opportunity because although we don't have any real scans from the target domain yet, we do know the tissue to signal intensity correspondence by design, because this is an intentional part of the development of the sequence. And so this allows us to take advantage of a setting between these two other settings where we don't have any actual images of the target domain, but we have some idea about what these images would look like in terms of their brightness. So we propose a method which only needs two things. So firstly, a dataset of any sequence as our source domain dataset, and this dataset must have labels for the pathology, which we are interested in segmenting, and also all the anatomical regions. And in the case of the brain, software can be used such as SynthSeg to automatically generate these. And then we also need estimates for the mean and the standard deviation of the intensity of the labels for the anatomy and the pathology in the target sequence, and these can be provided by the sequence developers. Here you can see an illustration of our method. We have the confounder sampling stage and the model training stage. Our method is inspired by SynthSeg. So in the confounder sampling stage, we start with the M anatomy and M pathology masks. Then we generate this M confounders mask, and we get the resulting label map L. Then for the model training stage, we perform spatial augmentation on the label maps, like in SynthSeg. Then for each label, we independently sample a normal distribution with the estimated mean and standard deviation for the new MRI sequence provided by the sequence developer. And we sample the confounder labels from the same distribution as the pathology label. And we do this so that the model doesn't simply learn to threshold the intensity of the pathology. Then we perform standard intensity augmentations like in SynthSeg. You can see the resulting image iTarget. And then we train a 3D unit with dice loss. We used ischemic stroke lesions as the pathology in our experiments. For the source domain, we used the Atlas dataset, which has T1 weighted images. And for the new MRI sequence or the target domain, we used the ILS dataset, which has DWI and FLAIR images. Here we visualize the different training methods we used for our experiments. So in red, you can see the models trained on synthetic data derived from the source domain dataset. This includes the realistic model, which is our method, which I described previously, and also the same method, but with random intensities instead of estimated realistic intensities, and this represents the synthseg method. Then in yellow, we have the models trained directly on the source domain, and this represents the domain generalization kind of setting. We have the source model, and this model is trained in the same way as the red models, but using the same spatial and intensity augmentations, but we simply train it directly on the source domain. So in this case, the T1 weighted images of the atlas dataset. Then we also use SLOrg, which is a sort of state-of-the-art method from the literature for single source domain generalization. They do some specific intensity augmentations, and they developed their method and tested it on anatomy segmentation for cardiac and abdominal datasets. And then, as a baseline in purple, we train a model directly on the target domain using a small amount of data which we use for the validation set of the other models. And this is to provide a kind of pseudo upper bound for the performance that we can expect to achieve. Here you can see the table of results. Each model was trained using 3 different random seeds, and the final checkpoints, the results from the final checkpoints were averaged. So you can see that our method, realistic plus confounders, performs closest to the real data baseline, which is the target model, and that including the confounder sampling improves the results overall, but does result in a shift from recall towards precision, which is not unexpected. We also performed experiments where instead of trying to segment the pathology, we tried to segment the anatomy. And here you can see that actually most of the models perform reasonably well. This indicates that in this case, contrast is less important than spatial information. And this makes sense considering we are now segmenting anatomy. And you can see that, in fact, the methods which encourage contrast invariance in their training, so SLOrg and the random models, actually make the least badly wrong predictions. And this can be seen by looking at their lower 95% Hausdorff distances. This image shows the effect of introducing the confounder sampling. The left 3 columns are DWI and the right 3 columns are flare. The middle row shows the predictions when the model is trained without confounder sampling. And we can see that for the DWI images, we make a lot of false positives for these bright artifacts. And similarly, on the flare, we make a lot of false positives for white matter hyperintensities. When we introduce the confounder sampling in the bottom row during the training, we can see that we largely reduce these errors. So to conclude, we presented a method that can take advantage of information about what a sequence should look like in terms of its intensities without actually seeing any real images. And this can be used to train a model to segment pathologies for newly developed MRI sequences. The method reaches a reasonable percentage of the baseline model's dice score and also outperforms models which do not make use of this additional intensity estimate information. The confounder sampling is effective at reducing the obvious false positives. And finally, with newly developed MRI sequences, eventually real patient scans will become available, and interesting future work could look at using this model as a base to fine-tune or incorporating it with existing domain adaptation techniques to utilize this slightly more relaxed setting. Finally, I would just like to thank all our collaborators, my PhD supervisors, and our funders, and I would like to thank you for listening.